Yep, there you are.
Well, hello.
Hello.
Thank you all for coming. My name is Mitch Savitsky. I am not a pharmacologist, but I am a physician. I trained in internal medicine and decided during my internship that, I decided during my internship as an internal medicine resident that they work too hard. The ones who I respected were seeing patients in the hospital in the morning, in the office all day, back in the hospital in the evening. And I was just starting a family. I thought, I'll never see my family if I'm doing this. Coupled with my rotation at San Francisco General Hospital emergency department during Halloween, that was quite the experience. I decided to go into emergency medicine, took electives that would help me do that, and practiced emergency medicine for 34 years until I retired a few years ago. So I have seen a fair number of hip fractures, as you can all imagine, as well as a huge number of people who fell. So I'm going to read this. It's essentially the same as what is on the handout out there. And I just want to say that fear of falling and the consequences of falling loom large among us. According to the CDC, each year, millions of older people, they define that as those of us over 65, fall. In fact, more than 1 out of 4 older people fall each year, but less than half actually tell their doctor. Falling once doubles your chances of falling again. So fall by itself is a risk factor for subsequent falls. 1 out of 5 falls causes a serious injury, such as broken bones or a head injury. Each year, 3 million older people, again over 65, are treated in the emergency department for fall injuries. Over 800,000 patients a year are hospitalized because of a fall injury, most often because of a head injury or a hip fracture. Each year, at least 300,000 older people are hospitalized for hip fractures, more than 95% of which are caused by falling, usually by falling sideways. The 1-year mortality rate after a hip fracture has ranged from 12 to 37% in a large retrospective study done in 2010, and a later study over a longer period of time showed the increased mortality rate persisted for 1 year, but then appeared to level off. Falls are the most common cause of traumatic brain injuries. In 2015, the total medical cost is greater than $50 billion, most of which was covered by Medicare and Medicaid. Now, what conditions make you more likely to fall? There are a number of risk factors that contribute to falling. Many of these can be changed or modified to prevent falls, and they include lower body weakness, vitamin D deficiency, and I have to add that this is now controversial, whether vitamin D deficiency increases your risk for falling, but we'll leave it at that. If you have difficulties with walking or with balance, if you have vision problems, if you have foot pain or poor footwear, and home hazards or dangers such as broken or uneven steps, throw rugs, or clutter that can be tripped over. My wife tells me that our house, because of me, of course, is a fall risk because of stuff that I have around. And last but not least, the reason for this lecture, the use of medications such as tranquilizers, sedatives, or antidepressants, and even some over-the-counter medications can affect balance and how steady you are on your feet. Most falls are caused by a combination of risk factors. The more risk factors a person has, the greater their chances of falling. Similarly, data shows that taking 4 or more prescription medications, called polypharmacy, also increases the risk of falling, with patients experiencing a 14% increase in fall risk with the addition of each medication beyond 4. This is due in part to polypharmacy reactions. And this causes a higher risk of drug-drug interactions that can lead to a prescribing cascade. A prescribing cascade develops when an adverse drug reaction is misinterpreted as a brand new medical condition, and then you're treated with more medicines to treat the adverse medical condition. The use of multiple medications can lead to problems with adherence, medication compliance in older adults, especially if the person has cognitive or visual impairment. A 2017 systematic review of observational studies suggested that drug regimen complexity is associated with medication non-adherence. A balance is required when prescribing multiple medications. I suspect that many of us in this room are taking several prescription medications. And risk increases not just with prescription medications, but for many over-the-counter medications as well. There's a list originally developed in 1991 by Dr. Mark Beers, now maintained by the American Geriatric Society, of medications that cause side effects in older adults due to the physiologic effects of aging. This list is called the Beers criteria. There are other lists in use to help prescribers use appropriate medications for the elderly, including the screening tool for older persons' prescriptions, STOP. I think they had to make that up, so the acronym would be good. And Fit for the Aging, FORTE. This talk is intended to provide information about medications which increase the risk of falling. In analyzing the utility of any medication, it's vital to consider the risk-benefit ratio. This means weighing the benefit of using the medication versus the risk associated with taking it. Obviously, for each of us, this has to be an individual consideration best made in consultation with your own healthcare provider. Please don't stop taking a medication prescribed by your healthcare provider after listening to this talk without first discussing it with your doctor. Now, the physiological reasons for a heightened fall risk with medications in the over 65 population are many. An increase in what's known as the volume of distribution. This is the amount of drug that the body can absorb and keep on, not just how much gets into your gut, but how much stays in your body. The increase in the volume of distribution puts someone at risk for having a greater concentration of the drug than would occur in a younger person, coupled with an age-related decrease in the liver's ability to metabolize drugs. An appropriate dose of a medicine for a younger person could be an effective overdose in the aging. In addition, diminished metabolism by the liver and excretion by the kidneys, which can occur even without kidney disease, results in an increased risk for side effects. Clinicians are often challenged with the need to match the complex requirements of their older patients with those of disease-specific clinical practice guidelines. These are generally medical society guidelines that say, patient has this is how you treat it. It includes medications as well as other things. As an example, for a hypothetical older female patient with chronic obstructive pulmonary disease, type 2 diabetes, osteoporosis, hypertension, and osteoarthritis, the relevant clinical practice guidelines recommend prescribing 12 medications for this individual. Clearly, there needs to be some balance there between what's following the guidelines and what the individual can handle. While the list of medications that increase fall risk is long, they generally fall into one of several categories. These include the obvious, such as opiate pain medications, sedative medications, such as benzodiazepines like Valium and other drugs, antidepressants, including SSRI, selective serotonin reuptake inhibitors, and tricyclic antidepressants, anticholinergics, which can cause sedation, and many others. In addition, the use of herbal or dietary supplements like ginseng or ginkgo biloba extract and glucosamine by older adults has been increasing. In one study of over 3,000 ambulatory people over the age of 75, almost 3/4 used at least one prescription drug and 1 dietary supplement. Often clinicians do not question their patients about the use of herbal medicines, and patients do not voluntarily inform their physicians that they're taking them. In one United States survey, 3/4 of respondents aged 18 and older reported they did not inform their clinician that they were using unconventional medications. Herbal medicines may interact with prescribed drug therapies and lead to adverse effects, underscoring the importance of physicians routinely questioning patients about their use of herbal and other unconventional therapies, and patients remembering to inform their physicians if they're taking such supplements. Examples of herbal drug therapy interactions include ginkgo biloba extract taken with warfarin, which causes an increase in the risk of bleeding, and St. John's wort taken with serotonin reuptake inhibitors, which increases the risk of serotonin syndrome in older adults. A study of the use of 22 supplements in a survey of 369 patients between the ages of 60 and 99 found potential interactions between supplements and medications for 10 of the 22 supplements surveyed. The most commonly used herbal medications in this group were ginkgo biloba, St. John's wort, echinacea, ginseng, garlic, saw palmetto, kava, and valerian root. Now, the internet is not always a reliable source of information about the use of herbal supplements, increasing the importance of informing your healthcare provider that you are considering starting or have started taking such a supplement. We'll talk about specific categories now, and this is by no means a full list of the 1,000 medications on the beers list. And you should be very happy for that. First, we'll talk about the category of opiates. The use of opiates comes with many risks as well as benefits. For this lecture, the risk of fracture is the most important. In a prospective study including over 539,000 individuals prescribed opioids, the risk of fracture was nearly 4 times greater during periods of exposure to opioids than during non-use periods. The risk was greatest during the first week after starting the opioids and then declined with increasing duration of use. I've written some examples of opioids medications, including fentanyl, which I'm sure you've all heard of, morphine sulfate in its various forms, buprenorphine, transdermal patch, piperidine, hydromorphone, methadone, fentanyl, hydrocodone, tapentadol, oxycodone, and many others. In addition, many of these opiates are used in combination with other drugs, typically acetaminophen or Tylenol. So while it may not say opiate on the big brand name label, if you read the ingredients, you should notice that it says opiates in addition to aspirin or Tylenol or whatever else they decide to mix it with. The use of sedatives, including anti-anxiety medications, is also associated with an increased risk of falling, as you might imagine. Sedatives make you less alert. If you're less alert and walking around, you might fall. Just a few examples are lorazepam, diazepam, chlordiazepoxide, temazepam, midazolam, triazolam, flurazepam, clorazepate, and oxazepam. That I can say them? Yeah.
Those are all prescription, right?
Those are all prescription. None of these are over the counter, either alone or in combination with other things, unlike other medications we'll talk about, which are available over the counter. Now, barbiturates, historically used as a sedative as well as to control seizures, are potent central nervous system depressants, have a low therapeutic index, which means the ratio between the toxic dose and the therapeutic dose is low. So it's very easy to go from this is the right amount to, oh, this is way too much. That's what a low therapeutic index is. Barbiturates are also highly addictive, cause drug interactions, and are associated with an increased risk for falls and fractures. Antidepressants, of which there are multiple types. We'll talk both about the selective serotonin reuptake inhibitors, SSRIs, as well as tricyclic and tetracyclic antidepressants. The SSRIs are frequently used as the first-line antidepressants because they're generally efficacious and they're well tolerated. And they're also harder to overdose on than other antidepressants. SSRIs are indicated for a lot of things: anxiety disorders, eating disorders, menopausal hot flashes, obsessive compulsive and related disorders, post-traumatic stress disorders, premature ejaculation, premenstrual dysphoric disorder, and somatic symptom disorder. So that covers a lot of ground. Several SSRIs inhibit liver enzymes. These help metabolize other drugs. So if you're taking the SSRI, it's decreasing the activity of the enzyme in the liver, which metabolizes other drugs. This can lead to a possible drug-drug interaction. And one example is tamoxifen, which is used to treat breast cancer. Also, prodrug opioids, opioids that are dependent on being metabolized in the body to a more active form, such as occurs with codeine, hydrocodone, and tramadol. In these cases, the use of some SSRIs decreases the effectiveness of the analgesic, leading people to just take more, which isn't generally good. While SSRI drugs can cause drowsiness, which increases fall risk, they're not as potent in this regard as tricyclic and tetracyclic antidepressants, who I'll discuss momentarily. Some examples of SSRI antidepressants include citalopram, escitalopram, fluoxetine, paroxetine, and sertraline. I'm sure you recognize the brand names of all of these. Either you've taken them yourselves or you know people that have. They're extremely commonly used. The other form of antidepressants are tricyclic and tetracyclic antidepressants. They're more likely to cause significant drowsiness as well as anticholinergic effects, thus increasing the risk of falls. The most commonly prescribed of the tri and tetracyclic antidepressants in the US are imipramine, amitriptyline, desipramine, and nortriptyline. Benzodiazepines are central nervous system active drugs such as antipsychotics, antidepressants, and benzodiazepines most commonly, and they are highly associated with the risk of fall. Benzodiazepines, or benzos as they're typically called, cause people to fall 1.5 times more often than those who are not taking benzodiazepines. Many of the commonly prescribed benzodiazepines were listed above, and you can refer to the outline under sedatives. I've talked about anticholinergics a little bit. That's a class of drugs that interfere with a neurotransmitter called acetylcholine, which is extremely common in the body and is how many nerves have an effect by releasing acetylcholine at the junction of one nerve to an end organ. That's called the synapse. If you block the uptake of acetylcholine or decrease the amount of acetylcholine, you can have anticholinergic effects, which are innumerable. There are tons of drugs that have anticholinergic effects. An analysis of United States medication expenditures between 2005 and 2009 found 23% of community-dwelling patients over 65 years old who had dementia were prescribed medications with clinically significant anticholinergic activity, including memory impairment, confusion, hallucinations, dry mouth, blurred vision, constipation, nausea, urinary retention, impaired sweating, tachycardia or rapid heartbeat. A case-controlled study found an association between anticholinergic use and the risk of community-acquired pneumonia. This is an added bonus to why you want to be careful with anticholinergics. They can precipitate acute glaucoma attacks in patients with narrow-angle glaucoma and acute urinary retention in patients with benign prostatic hypertrophy.
Do you have the names of those drugs anymore?
They're not in here. At usual doses, anticholinergic activity is most significantly elevated for, and here's the name of a bunch of drugs, but they're all generic, not brand names,
Okay.
except for one. Amitriptyline, atropine, clozapine, disopamine, doxepine, L-hyoscyamine, thioridazine, and tolterodine. Anticholinergic activity is also increased for chlorpromazine, diphenhydramine, which is Benadryl, and I'm sure many of you have taken that in one form or another. Nortriptyline, olanzapine, oxybutynin, and paroxetine. It's important to recognize that higher doses of an agent with low or moderate anticholinergic activity can still produce significant anticholinergic activity effects. And similarly, the cumulative effect of multiple agents that may individually have low anticholinergic activity can still produce significant deleterious effects just by adding up the relatively low contribution of each individual drug. Antihistamines, there are two broad types, H1 receptor antagonists. The first generation of antihistamines that were developed include brompheniramine, carbinoxamine, chlorpheniramine, clemastine, cyproheptadine, dimenhydrinate, diphenhydramine, Benadryl again, doxepin, doxylamide, hydroxyzine, meclizine, triprodil, and others. Many of these medications are combined with over-the-counter drugs for cold use. Actifed, for example, has one of these in it, triprodil. So it's easy to be exposed to these without really knowing it if you don't actually read the ingredients. The second generation of H1 receptor antagonists has much lower anticholinergic activity. These include fexofenadine, cetirizine, loratadine, desloratadine, and levocetirizine. Proton pump inhibitors. These are used to decrease stomach acid. PPIs such as omeprazole, Prilosec, should preferably be limited to less than 8 weeks duration because of the risk of bone loss, fractures, and other complications, which are not specifically relevant to this lecture, but still occur, like Clostridia difficile infections and pseudomembranous colitis. And lastly, sliding scale insulin. Something as common as rapid-acting sliding scale insulin to manage diabetes, it's on the Beers list as a medication that should be avoided. You wonder why. When it's used as the only medication to control hyperglycemia or high blood sugar, meaning there's no basal insulin, the body's not making any insulin at all, or you're not taking any other hypoglycemic agent, the rapid-acting sliding scale insulin has a heightened risk for low blood sugar, hypoglycemia in the elderly population, leading to a very high risk of falling. Finally, medications that increase the risk of bleeding, anticoagulants, such as warfarin, aspirin, and others, while in themselves don't increase the risk of falling, they certainly increase the risk of a bad outcome if you're on these medications, fall, and hit your head. The full Beers list is available online, very small print, I must say. And the link is at the bottom of the page. So that's the formal talk. I'm happy to entertain any questions if I can answer them. And thank you for listening. Yes.
You mentioned aspirin here. Now there's low dose aspirin indicated.
Look, well, for years, low-dose aspirin was indicated in people at potential risk for coronary artery disease and heart attacks, and 81 milligram low-dose aspirin per day was recommended. That's still recommended for people at very high risk, meaning you've already had a heart attack. They've changed the recommendations, and first of all, they say the risk-benefit ratio for taking aspirin as a preventative for future heart attacks and strokes kind of drops off to it's riskier to take it than to not take it for people over the age of 70, except for a few rare exceptions. So in general, if you've been taking a baby aspirin a day to keep yourself from having a heart attack or a stroke, and you've never had a heart attack or a stroke, you might want to talk to your doctor about stopping the baby aspirin. Julie?
And the risk there was for bleeding?
Yes. The risk is for bleeding. Any other questions about specific medications? John?
Regarding the anticholinergic types of drugs, because it's hard to know what medication will lead to those kind of effects, does it kind of make sense then that if whatever medication you're taking, you tend to have dry mouth or blurred vision or constipation or nausea or et cetera? I mean, it's a long list. Does it make sense then talking with your doctor about?
It's an excellent point. Since so many of these medications are available without a prescription, you don't need to talk to your doctor in the first place about picking them up at whatever pharmacy you use and taking them. And most of the time, particularly things like decongestants, you're taking for a cold, and the cold will go away, and then you'll stop taking it. But the anticholinergic effect can occur rapidly and put you at risk. So you should be very mindful when you're taking over-the-counter medications that you haven't talked about with your doctor for symptomatic relief of something like a cold, because you could have side effects. Should you stop those medications if you're finding yourself if you're having side effects? I would. I mean, it depends. Again, what's the risk-benefit ratio? The risk is having a runny nose versus falling and breaking a hip. I'll just carry tissues. You need to weigh the benefits versus the risks. Yes.
I've been taking Neurontin or gabapentin
Mhm.
for peripheral neuropathy for years. Are there any side effects I should be aware of?
Well, there's probably a million side effects. Tylenol has a drug sheet with this long amount of side effects. Are there side effects that will cause you to fall?
Yeah.
I would need to look it up. But remember that one of the risk factors for falling is neuropathy in the feet, not knowing where you're putting your feet. If the Neurontin gabapentin improves that, then that's a benefit versus the risk of, the fall risk of taking the Neurontin, the gabapentin.
I found that to be true.
Mhm.
After taking gabapentin, I was a lot less off balance.
So in your case,
I have the same
neuropathy.
neuropathy.
Yeah. So in your case, taking a medication has decreased the risk of fall.
Yeah.
That can happen.
Thank you. Thank you.
Sure. Yes.
I have neuropathy also, but I chose not to take any of those. But the medicines I do take have put me like I'm, what do you call it?
Immune suppressed?
Well, the doctor said, it's because of my medications that I take, because I take them for other things.
Mm-hmm.
So I was afraid to take something for my pain because, they tell you, go ahead and take it, but I don't know the long effects of it. And I suffer every day.
As
Yeah.
we all know, there are many reasons to take many medications. And again, using the risk-benefit paradigm, if you decide you want to take a new medication, you should ask your doctor, and your doctor can also look up the interactions of the new medicine with the medications you're already taking. That should pretty much be standard procedure in medical practices. And I know some large hospital systems with electronic medical records, that's programmed into the computer. So if, for example, you are taking a medicine regularly for blood pressure or for neuropathy, and your doctor prescribes another medication, they enter into the computer, and the computer has a program which springs up a warning saying, warning, this patient has also had this prescription, this medication prescribed. Be careful about this new one that you're putting in. So that exists both in large scale health systems, and there's an app on my phone that also allows you to assess medication interactions.
I remember, I think the word is immune compromised.
Uh-huh.
It's, I don't know, I got an alert from my doctor. I thought it was for an appointment. And so I looked at the message and she just said, you are immune compromised because of the medications that I take. So,
That's certainly possible.
and they make me dizzy.
I'm just like,
Oh, gosh. I have a hard time. Yeah. If I keep busy and don't think about it, I can carry on.
I think there's virtually nothing that we can take, either prescribed or over the counter, that does not cause some kind of risk of a side effect or drug interaction. And it's deciding whether to take something that helps your pain or doesn't. Yeah, how bad is the pain? It's again the risk-benefit ratio. And this is something you can discuss with your doctor. Julie.
Want to talk about these, Mitch? These forms that we had made up about going to your doctor and talking to your doctor about your falls. Want me to say something or do you want to say something?
You can say something.
Okay,
I think
so,
everyone here has probably seen those at one point, but I think it bears repetition. As I mentioned during the talk, a lot of people fall but don't tell their doctors. A lot of people take supplements, don't tell their doctors. And the doctor can make an informed medical decision about what you should be on or not on if they don't know what you're actually taking. So that's on the doctor, because they should ask you, or in most cases, the medical assistant asks you what medicines you're taking. But also on all of us as patients. We should say, yeah, I started taking glucosamine, or I'm taking turmeric, or I've had a cold the last couple of days, so I'm taking Actifed, whatever. No one's a mind reader here in either direction. So you really have to talk to your healthcare provider.
Can I say something about these?
Oh, sure.
Okay, so these are some sheets that these are some sheets that the fall advisory committee here at the senior center we made up because we had been talking to people who came here to talk to us about their lack of balance or falls. And it was clear that those people weren't knowing why they were falling or having a very clear understanding of within the dialogue with their physician. So this is called communicating with your doctor. It's particularly relevant toward fall risk, but it is just, and in general, it's a two-sided guideline for what to remember to talk about with your doctor, talking about, am I taking any medicines that increase my risk of falling? If so, can I stop them, reduce them, or replace them with something else? So these are available on the table back there.
Yeah, thank you, Julie. It's very important because when we go to our doctors, we often feel rushed. Have a list of things you want to talk about and sometimes forget about one of them. As you're walking out those, oh, I forgot to ask about this. So writing them down, having a format for how to ask questions is very helpful. So I recommend that you pick one of those up. Yes.
What is the term anti-cholinergic?
Cholinergic?
Repeat the question.
What does the term anticholinergic mean? So acetylcholine is a neurotransmitter, which means it's produced and stored at one end of the nerve. When that nerve gets stimulated, it releases little packets of acetylcholine that drift across the space, which is microns long, to the receptor at the other end, which could be another nerve, or it could be a gland. It could be a lot of different things. So an anticholinergic is a medication that interferes with that neurotransmission. There are other transmitters besides acetylcholine, but the anticholinergics prevent the acetylcholine from doing what it's supposed to do. So that's why you get those reactions. Yes.
What's a good way to advocate for somebody if I'm in the doctor's office with them to determine if it's an adverse reaction to a med versus a new medical condition?
Ask the question. I mean, sometimes for a lot of new medications, there will be a time frame within which an adverse reaction will occur. If someone's been on a medicine, stable dose, for weeks and weeks, and then they get some new symptom, it's probably not due to the new medication. However, a day later, 2 days later, they're feeling really woozy and dizzy, that's more suspicious, and then definitely want to investigate whether it's a new problem or is it related to the newly prescribed and newly taken medication. Yes.
Following up on your suggestion of being prepared at the doctor's office, often they'll say, are you on the same medications? Well, I find that to be a really poor way to ask what the patient is really on. And I say, read it off to me.
Yeah, good idea.
And because I can't always remember, and I always bring a list, and so I have them just read it, and they'll say yes, no, that was temporary, done with that, no, so, and it's because they're in a hurry. They just want to say yes or no.
Right. Some healthcare systems will send you, an email in advance saying you have an appointment with your doctor in 3 days. Here's a list of the medicines we have you taking. Can you just go down that list and say, yes, taking yet? Nope, not taking anymore. And that speeds things up a little bit, but in no way is it totally replace that. Here's what the person-to-person interaction, which takes more time, but allows for actual conversation. And you may have forgotten something. Oh yeah, I'm taking this. Just because it's not on the list doesn't mean I'm taking it. John?
I was really surprised to see this information about a 14% increase in fall risk for each new medication beyond 4 medications. That just sounds like,
As she said in the beginning of before we started talking,
oh yeah.
I shouldn't be able to walk at all because I'm taking so many medicines. I should be falling constantly. So I guess we're lucky. But yeah, for this particular study, that's what they found.
Yeah, I mean, it just sounds like a great conversation starter with your writer.
Yes. Yeah, the doctors on the other side of the problem as well, given you want to treat a patient appropriately. And what's considered standard of care is often what are the medical society's guidelines. The internal medicine or pulmonology docs say, this is how you treat COPD, chronic obstructive pulmonary disease. These are the medicines you use, or this is how you treat diabetes. And as I mentioned in the talk, someone with a common constellation of problems like diabetes and high blood pressure and COPD, you look at what each individual guideline, professional society guideline says, well, you should be on this, that, and that, and it just adds up. So you have to modify and take into account the risk-benefit ratio. Maybe you can do without one of those medicines.
I think one of my problems is that I go to more than one doctor. And I'm really not sure how they stay in contact, as I see a psychiatrist who recommends medicine for a particular problem. And then I see a GI, and then I see one for the neuropathy, you know. It's mind-boggling.
That's a huge problem. Some of the bigger systems which have A, electronic medical records, and B, offer your healthcare and all the different specialists within one system, in theory, can see what you're
You
being
have to do it
prescribed.
yourself. You have to hammer at the doctors. Gee, I'm really concerned about this or that.
Mhm.
You just
Yeah.
have to.
I agree. You need to talk to your doctor, let them know what it is you're taking. And, I was prescribed an antibiotic because I had skin infection by Dr. So-and-so. But, your other doctor doesn't know you're taking that antibiotic and could prescribe some medication that all of a sudden causes a drug reaction.
Doctors are so busy,
Yes,
that lots of times they just don't have the time to be super careful,
that's a problem.
as careful as they'd like to be. Super careful.
I'm sure you're right.
I've heard that one way to try and deal with that, if you're getting prescriptions from physicians who aren't necessarily communicating with one another, if you always go to the same pharmacist, you always have the same pharmacist fill your
Yeah.
prescription, then you might have a conversation with the pharmacist. who
That's
would do a review.
Yeah, that's excellent point. Because the pharmacy, independent of your doctor, will have their own list of medicines that they've been prescribed, that you have been prescribed, that they've dispensed. So if they dispense all your medications and then you're prescribed a new medication, their system will also pop up as a warning. Oh my gosh, you're taking A, B, and C. You should not be taking this new D.
Will they do that? Will they warn you?
Pharmacists
I
should warn
mean,
you, yeah.
I don't, I'm thinking that they might be worried because the doctor would be, feel put down. Wouldn't
No,
matter.
I wouldn't worry about that. The comment was, don't upset the pharmacist by questioning them. That's okay, question them. Same with your doctor. I mean, ask your doctor if you're prescribed something new, how will this interact with the meds I'm already prescribed? Because as you all pointed out, we all know, doctors are under tremendous time pressure. And they may not remember or think about, well, this could interact with that.
Well, they're not superhuman, so you have to add your point of view in.
You have to advocate for yourself.
Yep.
And if you don't feel comfortable doing that, bring someone with you if you can, who will. Any other questions? Thank you for coming here, for listening to me babble, and I appreciate it. Next week, Dr. Bernstein is talking about neurological conditions that can increase your risk of falling. And I'm sure that will be an excellent talk.
Including peripheral neuropathy.
Thank you.